Back in 2016, we did a study, qualitative and quantitative study about the caregiving community. So nice. It will be interesting to interact.
Yes, sir. Mahesh, you are there? Sheetal?
Hello.
Sheetal.
Yes,
Just greet everyone.
yes, good evening, sir. Good afternoon.
Yes. Zeba.
Yes,
Zeba,
good evening.
Ambali sir knows you.
Hello. Good afternoon, everyone. Hi, sir. Hello, sir. Dr. Sadhana.
Good afternoon. Welcome to this webinar.
Thank you, sir.
I also welcome Dr. Vinod, Professor Vinod sir, for this webinar. Welcome to you, sir.
Thank you very much, and I hope I am audible.
I think you should increase the some more volume.
I think as far as my computer is concerned, it is the maximum volume. But I will speak more loudly now.
Yes, sir.
can hear you.
Yeah.
So now I am audible?
Yes, sir.
Good.
Yes, sir, you are.
Okay, so Dr. Ambali, please, if you like, you can begin.
Yes. Shall we start, sir?
Yeah, I'm ready.
Vignesh, shall I start now?
Maybe just give 1 more minute or something. People are joining.
Very good afternoon to all of you here. At the outset, I welcome you all on the behalf of BLDE Deemed University, Shri B.M. Patil Medical College Hospital Research Center, Department of Geriatrics. Today we have a very important discussion on dimensions of geriatric caregiving. And we have a stalwart from India, well-known, recognized across the globe for his services, Professor Dr. Vinod sir. And we also have a dynamic Dr. Anil K. Patil to chair this session. So I bring greetings from geriatrics department when we started in 2007 as a geriatric clinic. Now we have 2 MD students in geriatric medicine for last 3 years. And we are also a recognized training center by Dementia India Alliance, National Institute of Social Defense, for training the nurses in geriatric care and dementia care. We have also launched a unique Reaching the Unreached program for older people in the rural village. We adopted one village, and that is happening for last almost 48 months now. And that the activity has been endorsed by United Nations as well. So today's topic, caregiver, this article I found recently. Of course, it is happening in India also. Most of the formal and informal caregivers, we all by default are caregivers for our parents and grandparents in one or the other stage of our life. The most important aspect is the caregivers doesn't receive the due recognition that they are supposed to. And Indian women, we always look here, they are sacrificing their job to ensure that they provide care for their in-laws or their own parents till the end of life care, and without even considering that it is costing their own health. So at the cost of their own health, they are providing care for the older people and without training. So most of the times they come to us and convey their problems and we try to solve them. That is, the caregiving issues are plenty. And today we have Dr. Vinod sir to give the solutions to most of the problems that recently the government of Karnataka has launched an interesting scheme wherein they provide a monthly allowance of ₹1,000 for the caregivers of people living with multiple sclerosis, muscular dystrophy, Parkinson's, cerebral palsy. And why I'm discussing this today is because our chairperson today, Dr. Anil K. Patil, has been a leader in advocating the government, the part of advocacy. And he is the person who is a part of this scheme that has launched by Government of Karnataka. And we are very lucky to have two stalwarts today for this program. And I now hand over to Dr. Vigneshwaran, resident of PG.
Good afternoon. Good afternoon to all and all present here online. I, Dr. Vigneshwaran, postgraduate, Department of Geriatric Medicine, will be your master of ceremony. I thank Dr. Ramli sir for giving a very beautiful preamble about this session. Now, I request Dr. Mudassir Indikar, Assistant Professor, Department of Geriatric Medicine, Shri B.M. Patil Medical College, BLDE, to welcome the gathering.
Very good afternoon, everyone. Myself, Dr. Mudassir Indikar, Assistant Professor in Department of Geriatric Medicine. On behalf of Department of Geriatric Medicine, BLD Deemed University, Shri B.M. Patil Medical College, Hospital and Research Center, I welcome you all to the webinar, Dimensions of Geriatric Medicine. I also welcome our stalwart faculty, Professor Dr. Vinod Kumar sir. I welcome our chairperson, Dr. Anil Patil sir. I also welcome our principal, M.B. Patil sir, and our professor and HOD, Dr. Anand Ambli sir. Thank you. Over to you, Vignesh.
Thank you, sir. Now, I request Dr. Sandeep Kumar, postgraduate, Department of Geriatrics, to give a brief introduction about our chairperson and faculty.
Well, I think Dr. Sandeep is in the wards. So I take this privileged opportunity to introduce our guest faculty today, Dr. Professor Vinod Kumar sir. I am too young, maybe too immature to introduce him for this August gathering. Sir was a pioneer in starting geriatrics in Department of Medicine in AIIMS long back. And then he was a professor and in PGI Chandigarh, and he also has served in various capacities at World Health Organization and UNICEF. And he has been a person in national policy of older people and various government schemes that the national government has brought. And he has been awarded with the Vayashrestha Samman from Government of India in 2011, and also the Delhi government recently awarded with Vayashrestha Samman. So with this brief introduction, I welcome Professor Vinod Kumar sir. Welcome to you, sir.
Thank you.
Sir, sorry to interrupt, sir. Dr. Sandeep Kumar sir has joined the session.
Now, let him introduce Dr. Anil.
Yes, sir. I asked Dr. Sandeep Kumar sir to give a brief introduction about our chairperson, Dr. Anil Patil.
Thank you very much, Professor Ambi. It is a matter of privilege to introduce Dr. Anil K. Patil to you. Dr. Anil has over 25 years of experience in international development sector as a development practitioner, grant maker, and trustee. Dr. Anil established Carers Worldwide in 2012, drawing on his extensive professional and personal experience, and continues to fuel his passion to transform the lives of unpaid family carers and young carers in low and middle-income countries. Dr. Anil serves as the founder and executive director of Carers Worldwide, an organization that works across India, Nepal, and Bangladesh to bring about systemic change for young, adult, and elderly family carers. He is the only international NGO exclusively and strategically addressing the social, physical, mental, and economical well-being of carers of chronically ill, elderly, and established and disabled loved ones. So far, it has transformed the lives of more than 180,000 carers and their family members. Dr. Anil is a recipient of several awards and fellowships. The notable one is that he became an International Ashoka Fellowship in 2015. Dr. Anil's focus is on researching and advocating for elderly and family carers. emphasizing their physical and emotional health, and addressing social isolation. Dr. Anil is dedicated to increasing the visibility of carers globally, shaping policies to improve their lives, and advocating for their rights to be enshrined in national legislation globally, fostering robust carers movement in each country. I welcome you, sir.
Thank you, sir. Now I request Professor Dr. Vinod Kumar, sir, to proceed with the presentation.
Thank you very much. I am really delighted to be with you, and I am very grateful to the BLD Medical College, which is a very prestigious college in the state of Karnataka, to have given this opportunity to me for presenting this talk. And I think I'm particularly beholden to our chairperson, Dr. Anil, who is so well known in this field. And I think my presentation will be like showing a dim torch to the solar system. And he has so many awards and experience. I am being a professor. I would be talking more of theory. And also, of course, I've been caregiver to some of my family members, or whatever little experience I have, I would be dwelling upon that in between. And you all know that India is a huge country, and it has a huge population of about 130 or 140 million, 60 plus people. And not everyone is fit and fine. I think many are sooner or later start getting some kind of problems of old age, maybe in the form of psychological marginalization, or maybe in the form of medical disorder and some kind of aging symptoms. And as you very well imagine, that when an elderly individual becomes largely dependent on his family members or on his near and dear ones, how difficult is the task of caregiving at the own cost of their own problems that a caregiver faces. So I think the answer to this question partly lies in the fact that we should vehemently promote what is called health promotion and health protection, so that more and more elderly remain independent for as long as possible. However, we will still have to face a lot of this population which becomes dependent sooner or later. And in our country, I think an interesting figure is that between 2000 and year 2050, although the general population increased by only 55%, from about 1,000 million to 1,500 million in 2050. But the people who are aged 60 and plus, they will be rising by as much as 325% population. And 80 plus is the fastest growing segment. They were about 8 million in 2000 year, and they will be about 48 million in the year 2050, 700 million increase. And why I'm bringing out this? Because it is the 80 plus or the 90 plus or even more advanced age people who are likely to be more dependent, for whom the caregiver work will be needed. So with this, I think I will now share the screen and here and now can you see the slide, please?
Yes, sir. Please make it
I will
slide
put
show.
it on the full screen. Yes. You can see the full screen now. Okay?
Yes, sir. Perfectly seen.
Okay. So this is the topic that was introduced to the audience. And I have already given a brief introduction about the problem. And as you know that I have already shared with you that old person can become partly or totally dependent on caregiver due to variety of limitations in his many activities, like mobility, memory problem. He cannot bathe himself independently. He has visual hearing. He has visual and hearing both defects. both impairments, I should say. And then he has also difficulty in dressing himself. He may have problem in climbing a stair. Using toilet is another problem. He sometimes finds difficulty in getting to the toilet, and he might lose his balance, and sometimes he falls. And I think you all very well know that older people fall is most common inside their homes and sometimes in toilet. And in extreme cases, he cannot even feed himself. So, and now this dependence can increase further as the old people may also face following adverse situations. This list, which is alphabetically arranged, is by no means complete. But first is age discrimination. I think society by large sometimes does discriminate against the age of the person, and this discrimination may take to the shape of sometimes neglect and even abuse. Then I think another problem which an elderly person faces, bereavements. As he is getting older and older, his near and dear ones start to leave this world. His spouse may go away earlier than him, and he loses the social support, emotional support. This is another problem which is likely to make him weaker and dependent. Then I think I would be talking in the next one about chronic diseases that he may have, and these are often lifelong, chronic, and at times they are life-threatening diseases which require constant care by the caregiver. Depression is another problem that they may have. As the age goes on and so many circumstances creep in his life, they can have emotional disorders like mood swings, anger, agitation, sadness, and all kinds of emotional disorders he can have, sometimes to the extent that they may have sometimes suicidal tendencies. Then they have, as they age, they cross the age of 60 and become more aged, their income keeps on falling, and they have some kind of fear of the unknown. And that unknown is often a fear of death. I think they all know that the brevity of life which is staring at them is going to lead one day to their departing this world. Generational disconnect. I think these days in the modern world, with the advent of mobiles, advent of computers and internet, I think they have lost the connection with, especially with the second generation, that is granddaughters and grandsons. Then healing and coping issues are largely because of declining immunity in old age. So if they get anything, this takes long time to heal. And similar is applicable to psychological stress. They cannot cope with the psychological stress the way they used to cope in their old age. And finally, very importantly, they become isolated, and many of them, they lead a lonely life. In our country, about 8% of people live alone, and there is a high dependency ratio. According to Lassie study, about 19 to 20% is the old age dependency. Now, caregiver may face more strain if the elderly person has got medical disorders and also some kind of symptoms which may not necessarily be because of these disorders, but they may even be present in the absence of these disorders, which I am calling them a normal aging symptom, but they are also troubling him at times. So disorders alphabetically arranged again, not going to enumerate. They are from A to I. Most of them are chronic, except sometimes infections, which may be short-lived. It may be chest infection, it may be infection of the urine, or it may be stomach infection, and so on. Aging symptoms are very important. As a person becomes older and older, particularly female elderly persons, they experience all kinds of aches and pains. Many elderly people can have chronic cough and breathing difficulty. Motility disorders lead them to constipation and difficulty to evacuate. Appetite, the amount of food that they take starts going down. They often feel fatigued and exhausted, and thereby they do not indulge so much of physical activity, that is sedentarism, and they also become forgetful. I am here not talking about Alzheimer's disease or dementia. It is just age-related benign forgetfulness, which also compromises the quality of the life. And then gums and teeth, chewing problems, digestive problems, all interrelated. Hearing and vision I have already enumerated. And finally, many elderly are not able to sleep properly and suffer the consequences of sleeplessness, which we call as insomnia. And of course, along with insomnia or sometimes independent of insomnia, they have leakage of their urine and sometimes fecal incontinence. And in the night, when they are not able to sleep, they often keep visiting the bathroom and pass urine in small quantities, but repeatedly disturbing their sleep once again. So with so many difficulties becoming a part of life of some elderly person, not everyone, it seems no other age group is so vulnerable to such multitude of physical, mental, social, and financial problems as to often require a multidimensional support care system based on strong ethical and legal principles. Now, what are the principles of ethical caregiving? I think this is a very important subject which has been dealt during the caregiving functions. Ethical care comprises of moral, spiritual, cultural, and economic rules of etiquette adopted by the caregiver to regulate his or her conduct while giving care to the patient. Ethical principles are at times neglected by the caregiver, or sometimes they are at conflict with the necessary medical decisions in the consideration of the caregiver, and consequently, ethical obligations are now heavily supplemented by and intertwined with health legislation, but they should still exceed legal duties. Ethics is very important and overrides every other consideration. Now, this is about the types of geriatric caregiving. Here I am classifying as two types. One is selfless caring, the other is profit-making industry. Selfless family members are the largest resource as informal caregivers and lessen definitely the demands on public health care system. They look after their own family members selflessly and thereby reduce the load on our government and our hospitals and so on. Sometimes friends and neighbors can also pitch in. Since the caregivers suffer from fatigue, stress, personal disruption by sustained caregiving duties, I think there is a point in stressing the need of government subsidies, tax incentives, long-term care insurance, and respite care should be widely available for support to caregivers. I was particularly happy when Dr. Anand Ambani said that 1,000 rupees are given in his state by organizations for giving caregiver to people suffering from disease like Parkinsonism and so on. However, I must hasten to add that with increasing modernization and thereby dwindling supply of family caregivers, which we call as informal caregivers, because many family members are also employed doing their job. So, and many they are involved in their other duties like education, college, and so on. So there is a dwindling supply of informal caregivers, and this has indeed triggered a formal paid private caregiving as a thriving industry, wherein compliance with the ethical and legal provisions to avoid misconduct, go back to the slide, to avoid misconduct, negligence and financial exploitation can at times an important issue. Now we have talked about care receiving by the elderly. Let us talk also something about caregiving, because these are the two extreme ends of a swing arm. So care receiving by aged, I think lot of talk, lot of noise is being made, rightly so, and there are many national programs that are available in our country. There are legal protections, there are ethical obligations, but what about caregiving? Are there matching resources and facilities for caregivers? In my opinion, although lots and lots of talks are going on, even for caregiving, but I think the resources and facilities available for caregivers are not so many, and I think something has to be done. Now, this is a busy slide. I'm not going to enumerate, but I'm happy to share with you that many of these national programs and policies. I was personally involved during the last quarter of a century. Most of these programs have been formulated by either Ministry of Social Justice and Empowerment, which is the nodal ministry for older persons, or by the Ministry of Health. And of course, there are many other ministries which are involved in various kinds of facilities provision for elderly people. To name some important ones, Ministry of Rural Development and Ministry of Panchayat Raj. And of course, so many ministries, including finance, they give relief, income tax, travel, transport ministry, etc., and so on. Now, these are the legal provisions that are available in our country. Directive principle of state policy in our constitution, Article 41 states that the government or the state within its limits of economic capacity will extend the significant, whatever is possible, help to the elderly people. The Hindu Adoption and Maintenance Act, formulated in 1956, mandates the provision of care of parents by the children, both by daughters and sons. Himachal Pradesh Maintenance of Parents and Dependents Act came much earlier than the Central Act. It came in 2001, and it also mandates to care for parents, the spouse, and the children by the population at large. And I think a flagship act, which was formulated at the instance of Ministry of Social Justice and Empowerment, is Maintenance and Welfare of Parents and Senior Citizens Act. It mandates not only caring for their parents and senior citizens, it also gives the power for the elderly people to receive maintenance from their children, the financial maintenance in the form of actual money. And also, it punishes those children who either neglect their parents or who abandon their parents or who usurp their property. So this is a very important thing, and I think we were a part of making the rules and this act in 2007 or 2006 earlier. Now we come to, after the legal protection, we come to ethical obligations, and these are the principles of medical ethics: autonomy, beneficence, non-maleficence, dignity, justice, and honesty. Principles of medical ethics, slight explanation is needed here, although most of you already know. By autonomy, I mean patient has a right to refuse or choose his treatment. You cannot thrust any kind of treatment on the patient. This infringes on his autonomy. And for the caregiver, it is his right to lessen the burden in order to get autonomy. Beneficence also applies to both, in my opinion. The caregiver should act in the best interest of the patient, while the society should also support the interest of overburdened caregiver in whatever way it is possible. Non-maleficence is a spirit of minimizing the harm to the patient during caregiver, and same thing, minimizing the harm to caregiver during his duties. Dignity, both patient and caregiver have the right to dignity. Justice, social justice, human rights, particularly health-related human rights, and equitable access to health care for an elderly patient. And reducing caregiver burden, especially for the family carer, is also a matter of justice. Honesty is about truthfulness in consent taking. So I would like to here say that ethical and legal obligations that I have enumerated, they apply to all dimensions and settings of care. And these are some of the settings of care that have come to my mind. The basic care I would be explaining a little later. Home care is one of the widest setting of the caregiving arena. Advanced care, it demands certain advanced kind of steps to care for elderly who are more sick. Then hospital care, institutional care like old age homes care, palliative care, that is end of life sometime, and hospice care, where the quality of life is the primary issue rather than reversing the disease which cannot be reversed. And of course, terminal or the end of life care. Now, very important, we talk of the tasks. I think there are umpteen number of tasks that a caregiver is supposed to give to his person. or give to his patient, or give to his dear and near ones, or give to his client if it is a private industry. And this basic care tasks are so many that I could only summarize some of them only in three headings: the wellness, the hygiene, that is personal hygiene, and accessories. Wellness may be as simple as giving company to the elderly person who can otherwise maybe walking, only feeling lonely. Homemaking, keeping his house safe, helping him dressing, maybe giving him counseling, emotionally keeping him assured, entertaining either by way of television or getting him listening to music or reading a book for him, interesting book, or anything else, or maybe taking him outside to the gardens, natural surrounding, helping in mobility, feeding, giving him proper diet according to his medical condition under advice, drug management, very important, uh, promoting him to indulge in some kind of physical exercise, giving him basic physiotherapy, and monitoring his vital like pulse, blood pressure, respiration, etc. Hygiene is oral hygiene, toothbrushing, shaving, bathing, nail care, feet care, hair care, bowel care, eyes, ear, and nose care, helping in toileting activities, and of course, hand hygiene is very important. Accessories, caring and cleaning for his artificial dentures, hearing aids, glasses, giving him bedpans and footwear, cleaning them. Also, same applies to urinals, changing diapers, taking his weight periodically, and checking not only his weight, but checking his vision, hearing, and so many other functions from time to time. These are the advanced care tasks. Of course, the training is important. All these are done under medical supervision, but they can be done anywhere, including at home. Giving insulin injections for a diabetic patient, giving all medicines in a particular manner as has been advised by the doctor. There may be many medicines, polypharmacy may be prevailing, and in later cases, pain may be a big issue for an elderly person, and one has to relieve pain according to the formulation that has been prescribed for pain relief medication. Drug-drug reactions have to be recognized. Adverse drug reactions, I think there are many drug reactions, and I think caregivers are told what are the drug reactions. They could be central nervous system drug reaction, they could be the autonomic drug reaction, they could be cardiovascular drug reaction, they could be GIT drug reaction. I'm not going to go into detail that, but the caregiver has to watch all those things. Then handling glucometer, nebulizer, managing his sleep, whatever sleep hygiene requires for that individual, helping him in speech therapy if it is required, assessment of geriatric for all the functional impairments, communicating necessarily at periodic intervals with the doctor, nurses, taking appointments with the laboratories and so on, and fall prevention, and even disposing the biomedical waste properly. Tube feeding, artificial hydration, which may be oral drinking water and fluids, or maybe IV, catheter care, bed sores, wound care, dialysis care, care of the specific disease that the person may be suffering from, a special care for the bedridden, and if necessary, in times of need, even give first aid or cardiopulmonary resuscitation. So what are the characteristics required from a caregiver? Is a tall order. I think you can imagine how tall this order is. So this individual needs patience, sensitivity towards the individual, a humane approach. He should be dependable and he should be well trained. He should be emotionally stable himself because he is going to get stress, caregiver burden, and therefore he has to be stable psychologically. He should be oriented to give such a service, and he should be dedicated. And of course, he should observe the ethical values that I have enumerated. I have already given the list. And now we come to caregiver stress. Caring for the loved one can be very rewarding, albeit its side effects like added workload, household disruptions, job losses, financial pressure, and this leads to changes in family dynamics, differences in the relationship between different family members living under the same roof, and all are being harbinger of caregiver stress. These are the signs of caregiver stress: exhaustion, resentment, anxiety, depression, irritability, sleeplessness, worsening health, poor concentration, he starts drinking, he starts smoking, he starts eating more, he overreacts. He sometimes he's completely helpless. There's no one to help him. And he may start neglecting duty and he has no time for his own leisure. So how do we recharge the caregiver? I think it's a tall order, but these are simple things that have been recommended by ARDSI Chennai chapter, and also there is a book I must advocate you all read about caregiving. Caregiving is written by Dr. Arvind Mathur, and some of these things have been taken from these and other resources. So speak up. So I think you have to tell the caregiver while he's undergoing training or while he is being counseled by you as a physician that he must speak up. If he is really feeling fatigued and feeling sad, he should not just keep silent. He speak up. He must share his problems with others. He should try to divide the responsibility among others who are available. If there is no one available, then of course it's a different matter. But sometimes the family members thrust upon a single person to give caregiving duties for long, long time and setting up a regular reminder. If some untraditional quarters is offering him an assistance, say yes. And make yourself laugh whenever you have time, even with the patient who may be reasonably fully conscious. Keep having a healthy jokes with him, or when you go out, or when you have chance to talk to family members or support groups outside, have a laugh, have a smile, and meditation. Dr. Arvind Mathur has given very good account of how a caregiver should engage himself in different kinds of meditation. And he should get out of the house, share his feeling. I've already told you, he should never compromise on his own sleep. Otherwise, he will feel fatigued the next day and he will not be able to give his duties efficiently. And as I said, he should join a support group wherever it is available. He should care about his own diet. And he should also keep undergoing his own health checkup if he is called upon to have long-standing sustained duties. He should not ignore his own blood pressure. He should also get his blood sugar down, health checkup, maybe once in 6 months or so on. And breathing exercise is another resource he can take. So now I come back to the older patient who is the care recipient. So what are the common ethical questions which especially abound in the care of older patients? Is the patient able to provide informed consent for the treatment? Is the patient capable of refusing treatment? If the patient cannot consent, who is to provide the surrogate consent? Is the patient safe to live at home alone? Can he be left alone? Is the patient at risk of exploitation or abuse or neglect? Can a particular patient continue to drive safely from his vision point of view, from his hearing point of view, from his cognitive point of view, from his balance point of view, and so on? And what are the goals of care? If an individual is really very sick and feel elderly, then our goals of medical care drastically change. Now, these are the specific ethical and legal obligations which I would like to emphasize while giving care to an elderly individual. One is hatching a very good rapport, communicating artfully, and learning the art of listening to older person. Second is observing the health-related human rights of the dear and near ones or the client. Consent for admission and treatment. An informal caregiver may not be knowledgeable about it, but he can certainly be a helpful component to the physician or to the other experts while a consent is being taken for admission and treatment. Same applies to advanced medical directive and living wills. Palliative and end-of-life care. A very well-trained caregiver can impart palliative and end-of-life care. This, of course, is a nurse-directed, medically supervised care. And finally, handling property and financial transactions. We come them briefly one by one. Rapid communication, art of listening. Make eye contact with the older person. Do not appear to him as if you are casual. You are listening to him and looking at some other direction. You should always give him a feeling that you are a patient listener to him. You are empathetic to him. Whenever you listen to him, you have a smiling face and encourage your patient to keep speaking and honor his experience. And while having a dialogue with him, keep maintaining his individuality. That means every individual, elderly individual or any individual for that matter, has developed certain styles of his life, certain habits, certain cultural experiences. So you should not thrust upon by talking too much on his, and whenever he is, you have to judge what is his individuality and smoothing that process of communication. Keep your own expression short, simple, and distinct. Never talk to him from his back or from his side. Talk to him while you are facing him. Of course, for those who are visually impaired or hearing impaired or cognitive impaired, special skills are needed, and there are handbooks available for that also available. Health-related human rights. I think it's common. There are lots of studies in India also. Not getting proper medicine, not getting proper nutrition, healthcare, and being subjected to abuse, rough treatment, bullying attitude, aid discrimination, and hasty discharges from the health facilities and hospitals is not a very uncommon experience. Dementia patients are made to suffer more. Often they are lying soaked in urine on the bed, and in the government hospital or in some other places, the bedpan is not provided for a long time, and he gets infection and bed sore, and he keeps shouting. It used to happen. It may be happening even now. I am not sure. So older patients have a right to be protected under that act, which is the flagship act of 2007. And additional protection is available for dementia patients under the Mental Health Care Act of 2017. And I think the last point is that the duty to provide is not only our duty to provide, it's not only the patient's right to receive, but we have to, it should be replaced by responding to health needs of the older person. What exactly are the different health needs of older person under your care, and realizing the health-related rights of older person. While you are giving the care, you have to, at every stage, you have to think that you are giving care by after realizing the human rights of that individual. Consent for admission and treatment. This is a legal document, and if an individual is in old age becomes incapable of giving informed consent, a psychiatrist or a substitute has to confirm and certify this based on the elderly person's level of comprehension, understanding, and capacity of communication. And this can be facilitated by using a document called Capacity Assessment Guidance Document, which is issued by the Ministry of Health and Family Welfare under Section 81, Mental Health Care Act 2017. Advanced Directive and Living Will, I think it has been a subject of great debate in our country now. Advanced Directive is a document, it's also called Advanced Medical Directive or Advanced Medical Planning, same thing. It is a document prescribing a person's wishes regarding the medical treatment that the person would want if he becomes unable to share his wishes or not in a position to make an informed decision by virtue of being vegetative or becoming terminally ill or demented and so on. So its purpose is to promote autonomy and benefits at a stage when he is in fully senses. So one, like a financial will, he can make a advance will or a living will. It's called living will. So living will is one of the advanced directives. Another being medical power of attorney. That's a kind of a surrogate. You can write in your younger age that he will be my medical power of attorney and this is my living will. In our country, this advanced directive or living will is closely related to passive euthanasia. You know, passive euthanasia, that is withholding the life support system like ventilator or feeding tube removal. When the person is in the terminal stage and the person is in a vegetative state, and then I think the question arises whether life support system should be withdrawn or can be withdrawn. This is called passive euthanasia. And passive euthanasia was legalized in India in 2018. But it was a little cumbersome process. Lots of permissions are needed. And in 2023, Supreme Court has also eased this advanced directive processing. I think this is not the time for me to go into the details. One can discuss it at the end of this webinar, of course. And this is palliative and end-of-life care. This is caring for an elderly patient for an incurable or terminal illness. It is chiefly aimed at improving quality of life of the patient as well as the family, rather than aspiring for reversing the disease. Palliative care requires a whole team of experts, including a psychologist and social worker and priest and so on. Here in our country, Panditji and things like that. This is the last one, handling property and financial transactions. Every elderly continues to have rights to own or inherit property, to manage its financial affairs, and to transact, sell, or give the property. He can ask for limited guardianship from the concerned authority if he or she needs support and decision making. The clinician can be made to pitch in for the process if required. Writing a will under the Indian Succession Act requires a sound mind, and in case of doubt, a mental health expert's advice may be needed. There are lots of stories about the dispute in these kinds of wills. There are lots of stories about the usurping of property, many of which have been addressed under the Maintenance and Welfare of Parents Citizens Act. Very interesting stories are there. Legal battles have been there over the last few years. And I think with this, I would thank you for kind listening. And I would only give a slogan that care for those leaving this world as much as we care for those entering the world. And with this, with your permission, I will stop sharing the screen. And
Thank you, sir.
thank you.
Thank you, sir. That was
Thank
a very thoughtful presentation, sir.
Thank
Get
you.
to know a lot of new information from your presentation, sir. Like over to Chairperson, Dr. Anil Patil, sir, for chairperson comments.
Thank you so much, Vigneshwaran. And thank you so much, Professor Vinod Kumar. Salute to you. Such an inspiring and thought-provoking presentation. I really don't have anything to say other than appreciating. You have covered everything. However, I will little bit focus on from the family carers point of view. That has been our experience, particularly the elderly carers. I have put together a few slides based on your comments I have incorporated. Just let me share that. I hope aim to finish maybe just after 5 minutes after 5. Hope that's okay with all of you.
Yes, it went again.
Are you able to see the slides?
Earlier you used to see, now it has gone. Tell them to reshare. Yes.
Okay.
It is getting shared. Yes, sir. Make it a slideshow.
Yeah, I'm doing.
Good.
Yes, sir. Seen perfect.
Well visible.
Thank you. Thank you. Just I will focus on caring and the carers worldwide, what we do. So this is the definition we use about carers. So who these carers are, family, particularly where there is no financial transaction takes place, and it is the family members who are caring for elderly and substance misuse and disability. One of the things I noticed was in low and middle income countries, currently we are working in India, Nepal, and Bangladesh, where Professor Vinod Kumar also highlighted carers are invisible. They are hidden behind the curtain. It is time for us to bring into the forefront, and they feel more isolated and more vulnerable because there is no support system for them. Again, I don't want to dwell too much on the carers facing the problems. Already Dr. Vinod Kumar has highlighted eloquently in his presentation. So one thing I want to share is, particularly in issues of carers, is that loneliness and isolation. They feel 91% of carers feel lonely and isolated during our survey when we carried out. And I want you to focus 30 seconds on this slide. Unfortunately, country like India, we don't have the statistics about how many carers are there. We have the statistics about how many elderly are there, how many people with mental health, how many people with dementia are there. But nobody knows how many carers are there. Whereas in the West, we have the statistics because it is part of the census. In UK, there are more than 6.5 million carers are in UK, or 1 in every 8 adults are carers. And the contribution made by the carers in UK, this is the study done by the London School of Economics and also Sheffield University, is 162 billion pound, which is more than the NHS National Health Service budget is there. And WHO also talks about by 2030, there is going to be 400% increase in need for carers, particularly in low and middle income countries. What I'm trying to paint a picture through this slide is literally we are sitting on a bubble. We don't know when that bubble is going to burst. It is time for us to think about supporting carers, strengthening the family system, creating a nurturing environment within the family. Again, in the absence of statistics, we started collecting the data about the carers. It is so shocking and staggering. These are the data from 3 countries. 89% of carers are anxious and depressed because there is no support system for them. 86% are finding physical health issues. And almost everyone is worried about the financial worries. And there is no concept of respite, no break for the family carers. And of course, the young carers, they are so isolated. And one side we talk about right to education, other side they are missing from the vital education. But there is a crisis. Again, Professor Vinod Kumar has highlighted beautifully in his presentation, due to life expectancy, combined changing with the population structure, for example, smaller family sizes and the reduction in extended family living. So the more and more caring is falling onto the family member, which are nucleus in nature. I do not want to dwell too much again on this carers and the elderly challenges. This is the HelpAge India report in 29, particularly elder abuse in India. This, you can see the statistics. Why this is the case? Why so much? Because there is no support to caregivers. Nobody is talking to carers. How are you? And do you need any help? Do you need any support? Everybody is coming and asking, how are you? How is your husband? Or how is your grandfather and all? As if this carer is a piece of furniture in the house. It is time for us to reflect and think about that issue as well. It is important. And again, Professor has highlighted in our survey also, we came across majority of carers are women. 84%. In some other countries, it goes up to 97%. One side, carers are very proud and happy to care for their loved one. Again, highlighted Professor Vinod Kumar. But again, carers are also getting older. So one of the concern for them is, what happens if I die tomorrow? Who is going to look after my loved one? So this is a real issue. We all need to put our heads together, come up with some kind of approaches and a solution. I'm not saying one size fits all, maybe different contexts and different region, different approaches, different solutions will be there. So it is important we come up with something to address that fundamental concern and challenges and issues many elderly carers are facing. I do not have to emphasize more on this importance of carers. Again, Professor has highlighted, there are 3 key stakeholders are there. what I call this is a triangle of care or partners in care. One is a care receiver, another is a care provider, and the third one is a professional, whether it is a geriatrician or pediatrician, whatever it is. So quite often professionals engage the carer how to take care of that care receiver, the need for carer. But unfortunately, we fail to engage the carer, fail to ask a question about the carers themselves, how we could help them to deliver the good quality care, and what are the one or two things will make their life better, but we fail to ask that question. So importance of carers. I really want to highlight these four key learning from our experience last 10 years. We have been working with the family carers. Friends, I want to say that to healthcare system, carers are the unpaid army, keeping everything going on. Without carers, our health system will collapse, but nobody is thinking about from that perspective. And to service providers, many thousands and thousands of organizations doing incredible work, but carers are the potential catalyst for therapy success. How much time we as professionals give to the family member? Maybe if we are lucky, maybe half an hour, 40 minutes or 1 hour, but it is the information we provide to carers. They are the one like turning that treatment into treatment plans into reality. Carers are the expert by experience. They may not know how to read or write. They may not have gone to university, but they do know how to care for their loved one, whether it is elderly carers or a person whom they love dearly. But at the end, carers are indispensable. Without them, nothing moves. They act as brothers, father, mother, husband, grandparents, parents that makes each day possible. So I do not want to focus again on carers worldwide. We have an ambitious vision and all. So we act as a catalyst to bring about systemic change in the country where we are working, and also provide the support to carers to improve their health and well-being, to improve their financial situation. Just I will share. So this is a simple model I have come up with, how we could not only empower carers, but improve their health and well-being, and also improve their quality of life and the quality of care as well. These are 5 simple elements. One is to reduce their loneliness and isolation, promoted carer support group. Again, Dr. Ambali has highlighted, Karnataka government has really listened to our work in the Karnataka state in 5 districts we are working. When we shared the evidence, we were able to see that 91% of carers' loneliness isolations were reduced through this peer support group. And last year, they issued an order to promote 7,000 carers groups in Karnataka alone. And they have requested us to provide the training to their rehabilitation workers. So second is, although they are caring for elderly or somebody needs the care, but their health and well-being is also important. So we organize a health service, provide health services through primary health care center. And the third element is, it is important carers have some break or a time off. So we promoted a community caring centers. So more than 60 centers are operating where 2 adult carers are caring for their loved one. So other primary carers can take time off for 2 hours, 3 hours, or 5 hours to go to market, buy vegetable, spend time with their family members. And of course, the financial issue is quite critical. We look at the carers' skills and expertise, and we make a link to the market. And when we started the work, only 30% of carers had regular income. Today, more than 80% of carers are earning up to 500 rupees per day. Finally, we promoted platform for carers to advocate for their issues, challenges, and difficulties. Today, we have 18 such organizations promoted at regional and national level. So, in fact, again, one of the things that Dr. Ambali has highlighted, thanks to, we do not want to claim ourselves that we are the only organization. It is the collective effort of our partner organization, carers, and all other service providers that were instrumental uh, in highlighting the importance of carers issues. And now the government of Karnataka is providing caregivers allowance of 1,000 rupees for those 4 categories. That is fantastic. Also, we have made a case part of Manrega. Why can't you give the caregiving itself is a job? Like, for example, elderly carers, they can't go out and work in the field and do the hard labor job. Why can't you consider caregiving itself as a job? That will give like at least 100 days of assured income for many families living below poverty line in the elderly case. Now this file is in the central government, and both Karnataka government, also Odisha government has endorsed our a document and shared with the central government. Like, our intervention is like a drop of ink in a bucket full of water. You don't need a whole bottle of ink. Just a little bit of support to caregivers really makes a huge difference. Just a simple things. It's not a rocket science. It's more of a common sense. Of course, caring affects everybody. It doesn't discriminate whether you are rich or poor. It affects president, prime ministers, affects actors and astronauts. It affects singers, scientists as well. So this is a universal issue. How can we not only raise the awareness, but also start supporting, looking at within our families and our relatives? If there are carers, please just ask one thing you can take message from today's webinar is identify them, ask them, how are you? Do you need any help? Just those 2 simple things will make a huge difference. So call for action, particularly the elderly carers. One is, these are the 4 things. There is an increase in awareness about the importance of family caregiving, and provide an education and training to the family caregivers, which again, I'm re-emphasizing what Professor Vinod Kumar has highlighted. And it is important to provide support and resources to family carers, and expand access to professional caregiving services for older adults who do not have a family carers. Again, Professor Vinod Kumar has highlighted that important to develop policies and programs that not only recognizes the support, the role of family carers, but also providing care to the older adults as well. So we needed different kinds of solutions and approach. I urge policymakers and even academicians and practitioners to think about these things. So it is important to invest in community care and support and recognize the importance of informal care and the people who provide it. So this is my final point. There are 4 key points I'm trying to highlight here. One is recognize the vital role carers play, change the practice to ask about the health of carers alongside the patient, and carry out a research on the impact of caring, which I have highlighted, and encourage opportunities for respite and a short break, may include daycare centers, so gives little bit of respite for primary caregivers. As I highlighted earlier, that caring affects everyone, so support for carers needs to become a mandatory, not an optional. So thank you so much for listening, and for more information about us, please do look at our website and all social medias. So thank you so much, Dr. Ambali, for the opportunity to share and chair this session. I really echo what Professor Vinod Kumar has said. Both person receiving the care, person providing the care, I would say that I will go one step further. It is important to strengthen the family. Look at whole family as a unit, and strengthen that family so that everybody can look after the person who need the care. So thank you so much.
Thank you, sir.
Thank you so much, sir, for the very insightful messages Dr. Vinod sir and Dr. Anil Patil gave. Not only the basics, what a doctor can do and all the society can do for the community. And now the session is open for question answers. If anybody wants to ask doubts to Dr. Professor Vinod Kumar sir, they can unmute and ask. There are a lot of compliments to you, sir, Professor Vinod sir, regarding your talk in the chat box. And thank you. And you were non-stop and in the same speed, the frequency for 45 minutes. And that's what the hats off to you, sir, for that stamina you are having now at this age as well. You are truly inspiring. And anybody wants to ask questions is open. Okay. So nowadays, yes, please.
Good afternoon, sir. Actually, I was doing my thesis in elderly abuse and in the rural area of West Bengal. And there, what I saw generally when I'm collecting my data, the elderly are very much attached to the son-in-laws and the means not in son-in-laws, sorry, the grandchildren, especially those who are in the school. So, what about taking the initiative to give some caregiving training to the from right from the school level? We can teach in the school level itself. If we can inculcate this kind of things to the students. So the future, because they are the future caregivers. If they then when these grandchildren they are motivated, that thing will come in future. It will be good. I think.
Can I answer your question? Can I answer your question?
Yes, sir. It's for you only. You are the right person to answer.
Oh, well, countries like India and Japan and some other Asian countries, they have an inbuilt cultural ethos, what is called Confucius filial piety. Now, Confucius' principles of filial piety is that as you grow up in a family, you are already told directly and indirectly that you have the unbounded duty to look after your parents and grandparents. And this is exactly what is happening in spite of having no training at all. Most informal family cares in India and maybe in some other developing countries are not trained. And you will be happy to know still that there are umpteen number of organizations in our country for last 25 years who are imparting short-term, mid-term and long-term courses on caregiving. But where are these caregivers going? Are they getting jobs as caregivers? Or are they getting trained only to look after their family? I think no. None of them is getting admitted for such certificate courses for caring for their family. They are all looking for job market. And the job market in our country is huge. And I would take a cue from Dr. Anil Patil's point here that, as I also mentioned in my own, one of the transparencies, that the private paid care industry has taken off in a big way in our country. But what is happening that many people from USA who are coming down and settling here, who had some kind of a exposure and training in caregiving, they are opening big organizations here which are all about caregiving, all kinds of caregiving, even for well-to-do, apparently healthy elderly, even for the compromised elderly, the sick elderly. But I'm sorry to say that these private houses, the charges that they are having, they are beyond a common man's reach. They're very, very expensive. 1 lakh, 1.5 lakh, and 2 lakh per month. But unfortunately, we still do not have a system where an affordable caregiving can be given. At the same time, we also do not have a system of helping out the caregivers themselves. And I think training at the level of the school student for caregiving will be, I think, a little extra work for the child who is already doing lots of other syllabi. So by the time he becomes older enough, he will not be able to pursue that training or refresher courses. I think enough is that he is being taught in the school what is called the moral science, filial piety. So this is what is being done at this stage. But certainly in the later young age or middle age, if somebody is imagining that he may have to become a caregiver, I think doors should be open for his training. In Japan, for example, what is happening? Japan is a country where the maximum percentage of older persons live. There are about 30% of people above the age of 65. They account for about 30% of the population. You can imagine. We are only above 60, we are accounting only for about 10.5%. They are accounting for 30%. So you can imagine how many old people are there and how much a family caregiver can contribute to the caregiving duties. So they have come to an innovative new idea. In year 2000, they started what is called long-term care insurance. So long-term care insurance, what they did, they asked everyone above the age of 40 in Japan to start giving the premium in an expectation that this you may also become an elderly and dependent later on. So they are charging premium from everybody. And therefore, the shift of the load of the caregiving has shifted from the family carer to the social care. The entire country is taking part. So that kind of something of that sort has to be innovated. And I am very glad that I have only talked about theory, but I am very glad that Dr. Anil Patil is actually doing a lot of things at the grassroots level, and he knows the ins and outs of this whole thing. And I would assure Dr. Patil that sitting in Delhi, I would be ready to help you out from the government perspective. And here I would hasten to add here that about 6 months back, it was only the government of India, not a private organization. Government of India asked the planning commission of our country, that is Niti Aayog, that could somebody talk about the ethics of caregiving in our country. It is not a much talked about subject in the eyes of the government. It is talked about a subject in the private organization, in NGOs. So this is how the government reached me and asked me to prepare a lecture on ethical and legal applications for ethical caregiving for elderly in India. And I think some few months back, I gave the lecture. And when I gave that lecture, I thought it is a very important area which has been neglected for so long in our country. And I think it is an ocean of opportunities. And I would seek the guidance of Dr. Anil Patil to go further in this direction. Thank you. And somebody also asked about I think I saw in chat box, what is sandwich care? I think sandwich care, but well known is that sandwich care is someone who has to look after his parents and grandparents also, and he has to also look after his own children. So he gets sandwiched between the two, and he has more power, more work to do. And whether he also suffers from more caregiver burden and stress, I don't know. A lot of research has been done. I have seen the papers on sandwich caregiver, but I think Dr. Patil is the best person to dilate it further. Thank you so much.
Thank you, sir. Any other questions anybody wants to know?
Will Dr. Anil Patil kindly tell us what exactly he does? I mean, how does he approach the caregivers, or what are the various kind of services or whatever help he gives to the caregivers?
Good to see you, Dr. Mangala Borkar. And
thank you, sir.
So our approach is we work through a partner organization who are already providing the services to elderly or person needing the care, person with mental health issues or disability. So these are the organizations who are already working in their communities for decades in terms of empowering elderly as well as people with disability and all. So they have been using carers to provide the care for their loved one. But of course, as I said, the carers are feeling proud and good about caring for someone they love dearly. But if it is a short period of care, we all do. Long-term care, which Professor Vinod Kumar was talking about, which is having a significant impact on them. So that is having a lot of challenges and difficulties for the carers. So when you ask the care receiver, initially my wife used to give a very good care. Now she gets angry, agitated, and doesn't provide that quality care. But the question is why? Because there is no support for the carers. Nobody is asking that question to her. So we do those 5 things. We provide training to our partner organization staff to identify who this primary caregiver is and understand their issues and challenges and the difficulties. That model which I explained in briefly. So I'm more than happy to have further conversation with you, Dr. Mangala.
Thank you, sir. Thank you so much. And we will be in touch with you. Again, I'll be sharing your email ID and contact details to those who need.
Please do.
Yes, sir.
Please do.
So I think we should conclude. Dr. Vinod Kumar, sir.
Thank you. Yes, if you can.
Dr. Vignesh, just I was remembering what Dr. Mani, even Dr. Anil said the same last 2 years back. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. I think that's the apt for what Dr. Vinod sir discussed today. All this. So over to you, Dr. Vignesh.
Thank you, sir. Now I request Dr. Suma Rato, Senior Resident, Department of Geriatrics, to deliver the vote of thanks.
Good evening, everyone. It's a great honor and privilege for me to propose a vote of thanks on this memorable occasion. Firstly, I would like to express my gratitude to Dr. M.B. Patil, sir, in charge principal, Dr. Shri B.M. Patil Medical College and Hospital, Vijapur, for allowing us to conduct this event. I would also like to thank Dr. Anil K. Patil, sir, the chairperson of this session, founder and executive director of Carers Worldwide, for gracing this occasion. I express my heartfelt thanks to Dr. Vinod Kumar, sir, the respected faculty of today's session, for his critical input on the topic. I would also like to thank Dr. Anand Amli, sir, HOD, Geriatrics, Vijapur, for his guidance in making this event a success. Lastly, I owe special gratitude to all geriatric medicine staff, including moderator of today's session, Dr. Mudassir Indikar, sir, Dr. Abrar, sir, and coordinator Dr. Anirudh Tumarchi, sir, postgraduate student, for their assistance in managing the event. Once again, thank you all for your attention. Thank you.
Thank you so much. Thank you, sir.
Thank you. Thank you. Thank you.
Thank you, Vinod Kumar, sir. Thank you very much.
Oh, Dr.
Sir, it was excellent.
Thank you. Thank you.
I'll be in touch with you, Professor Vinod Kumar. I will get your details from Dr. Ambali.
Good. Thank you so much. Thank you.
Yeah. Okay.
Okay. Bye.
Thank you. Bye.